Hey, this is Beth Wright, and I am providing you a podcast with the musculoskeletal unit, and this is titled Acute Injuries. It will involve Chapter 43 in your Adult Med Surg textbook and Pediatrics textbook Chapter 51. So we're going to talk about contusions, sprains, strains, and dislocations and fractures. So I think as one of your objectives, talks about prevention of acute injuries, and we've got to consider specific things that can help prevent injuries like this. And so, of course, car seats for children, the correct car seat is important, and I think you cover a little bit of that with your OB course. Also, the use of seat belts have, obviously been proven to help with acute injuries, especially if in a motor vehicle accident. Child-proofing surroundings. We have a grandson now, and he's almost 2, and I've been thinking constantly and doing things around my house to childproof surroundings to keep him from having acute injuries. So that's a big job when you have little ones around. Fall risk assessments are important as far as when we're working with our patients and considering in their homes. I know one of our clinical assignments is doing the home visits, and so doing that fall risk assessment is really important to help with prevention of acute injuries, especially when we're talking about hip fractures, pelvic fractures, things like that for our elderly clients. Helmets also are important when we're talking about bicycle riding and skateboarding, things such as that. Helmets are important to use and to encourage and do education with their young age population that's going to be doing those kinds of things. And then also considering, when we see clients come in to the emergency department or taking care of them in the hospital setting, considering abuse. We have to think about that when we see acute injuries. Does the injury match the story, and the assessment of the injury? And, if it doesn't, then, what's our course of action? We are, as healthcare providers, we are mandated reporters of child abuse. So, when we have a suspicion that there is some type of physical abuse, or not just physical, but here we're talking about, seeing acute injuries. So when we suspect a, physical abuse type thing going on, then we are required to report that to Child Protective Services. So knowing the process of how to report those things in the hospital setting that you work in or will be working in, or whatever setting you're working in, is it's going to be important for you to know that, because you will be considered a mandated reporter. So we've got to think about abuse, because we know obviously that does go on, unfortunately. So contusions, we'll start off with talking about that. It is a blunt force injury to soft tissue, so you're going to have ecchymosis, which is bruising, hematoma, and a hematoma is a blood collection, kind of like a pocket of blood that's usually clotted. We're going to see pain and swelling and dislocation to that area. And, with that hematoma, the acute or the contusion, the acute color of that is going to be a black blue looking color, and then it'll start turning yellow over a few days there. And it usually resolves in about 1 to 2 weeks usually. The treatment is intermittent application of cold packs applied with pressure to the site and elevation above the heart level. So that's usually how we treat that kind of thing. And this is just a picture of a hematoma or a contusion to a little one there that's bumped his head pretty good. So you can see what that might look like. It's a pump knot, if you will. Okay, and then a sprain is a musculotendinous strain injury, also known as pulled muscle. It's where it's overused or overstretched or excessive stress of that musculotendinous area. And there's 3 grades of severity, the first being a mild stretching of the muscle or tendon, and you usually see minor edema, tenderness of course, and maybe a mild muscle spasm of the strain. The second one is a partial tearing of that muscle or tendon in the second degree. And with this, you might see a loss of load bearing strength, and you'll see edema, of course tenderness, muscle spasm, and possibly some bruising in this one. And then our third degree is our more severe degree, and that's where we have a rupture or tearing of that muscle tendon that's happened, and we're going to have significant pain here. Muscle spasms, bruising, edema, and a loss of function. Now, an MRI will show this with the tear or the rupture. An X-ray will not show this, but an MRI will. And so you see an example of a third degree tear where you have a healthy shoulder on the left side of the picture. And then you see the rotor cuff tear, which is a common injury of the shoulder where that muscle tendon area is completely torn there. So you can see that. A rotor cuff tear is a tear in a tendon that connects one of the rotor muscles to the humeral head. And that rotor cuff stabilizes the humeral head, and there's 4 muscles there that connect, and their tendons as well. So usually when there's a rotor cuff tear, it requires an arthroscopic debridement, which is removal of the tissue that's not working there, or a orthoscopic or open acromioplasty with tendon repair there. So postoperatively, with this kind of injury, the shoulder is immobilized for several days to around 4 weeks, and then physical therapy will start working with them with shoulder exercises, and they have to start doing that. And it's a long drawn out injury. It can last up to 6 to 12 months for the rehabilitation of this type of injury. Now let's talk about a sprain, and that is an injury to the ligaments, the muscles, and tendons of the soft tissue around the joints, and it's caused by that twisting motion or a hyperextension of the joint. And again, we have 3 degrees, of the first being the mild one. It's where stretching of those ligament fibers have taken place, and you'll see mild edema, local tenderness and pain when the joint is moved. The second degree is a partial tearing of that ligament, and again we'll see edema, but an increased amount of edema and pain in that joint, and partial loss of function with that. And then the third degree being the worst, and that's where the ligament is completely ruptured or torn. And with this, you're going to see severe pain and tenderness, and an increase in edema and abnormal joint motion. You may see an avulsion fracture of the bone. What that is where there's an injury to the bone in a place where a tendon or ligament attaches to the bone. And when an avulsion fracture occurs, the tendon or the ligament pulls off a piece of the bone. So that's a pretty serious type of injury, and will take some time for recovery on that. Of course, treatment for all of these, RICE is our acronym that we use, rest, ice, compression, and elevation. The ice is intermittent application, for the first 72 hours. Compression is where we put a bandage on, or elastic compression bandage that can help control bleeding and reduces that edema and provides support for that tissue that's injured. And then elevation helps control the edema. Also, we're going to be doing that neurovascular assessment, so don't forget about that. I always want to do that when we have any kind of edema going on, because we are concerned about compartment syndrome. Heat application will be after the first 72 hours of injury. So that's going to be an intermittent type thing, usually leave on 15 to 30 minutes. Immobilization may be needed initially, but then, we do want to start that exercises as soon as, the physician lets us know that we can have exercise started, and weight bearing is also important to note from the physician's orders or the healthcare provider's orders. Third degree sprains or strains, definitely could involve surgical repair, and so we're talking about pre-op care, post-op care there, and immobilization afterwards on the post-op end with splints, braces, and cast. So the care of those musculoskeletal modalities is going to be important. So making sure they're not on too tight, assessing after application, and definitely teaching for any of those things for the patient with splints, braces, and cast, how to recognize when there's a problem, and when to seek help, that kind of thing is going to be very important. And also crutches. I don't have that listed there, but crutch walking, making sure that the patient's crutches are the right size, that's going to be extremely important. And then, that they know how to maneuver those, how to go upstairs. Also walkers, not just crutches, but walkers and canes as well. So any assistive devices is going to be important in this kind of treatment. And then, of course, exercise, after, the initial recovery there, starting that as soon as possible, and utilizing our experts in the field, being physical therapy, occupational therapy. It's going to be real important for recovery there and for rehabilitation. Okay, so dislocations we'll talk about now, and that is where a joint is dislocated from the articular surface, and and it can be distal and proximal areas that form the joint, and they're no longer in an anatomical alignment. So this is where, again, the joint is dislocated, and I'm going to show you a picture of one here in a minute. A subluxation is a partial dislocation, and that does not cause as much deformity as a complete dislocation. In a complete dislocation, the bones are literally out of the joint, and that is considered a medical emergency due to the blood supply being compromised, and it can result in avascular necrosis to that area. So very important to get that taken care of as soon as possible. So signs of a traumatic dislocation includes an acute pain, a change in the positioning of the joint, shortening of the extremity, definitely a deformity, and decreased mobility. And an x-ray of both the affected and unaffected side will confirm that dislocation or a subluxation. The joint is immobilized once they are getting treatment by splints, cast, or traction, and is maintained in that stable position. Of course, it's going to be important to do pain management with this patient. The neurovascular assessment is going to be really important there, because we're again concerned about that compartment syndrome. And then doing passive range of motion with the areas. If it's a shoulder, we're going to do passive range of motion with the arms, the extremities of wherever that joint is located. We're going to keep other parts of the body moving. So you can see this is a right shoulder, but you can see on the left side of that picture where it's a normal shoulder, but then look at the right side of the right shoulder there. The right side of this picture shows where that's completely pulled away. So this is a shoulder dislocation. Just completely pulled away there. Okay, now let's talk about fractures. So in your textbook, page 1160, chapter 43 is where it starts talking about the different types of fractures. And a complete fracture is when the bone is all the way broken, all the way through the bone. An incomplete fracture is that the break isn't all the way through the bone, and sometimes you might have heard this called as a hairline fracture. So it's that's not as serious as a complete fracture. A closed or simple fracture is one that doesn't go through the skin. So there's a fracture, but it doesn't come through the skin. An open or compound fracture is when the bone literally comes through the skin. And with the compound fractures or the open fractures, there's different grades of seriousness there. Grade 1 is where there's a clean wound and it's less than 1 centimeter. Grade 2 is where there's a larger wound and extensive soft tissue damage has taken place. And a grade 3 is where it's highly contaminated and extensive damage and is the most severe. And I'll give you an example of that. My husband played football when he was in high school, and during a play he sustained a I think he refers to it as a Joe Theismann injury, where he sustained a compound fracture during a football game where the bone came out of his skin. So he had a grade 3 on that with being on a football field and that kind of thing. So an intra-articular fracture is a type that goes into the joint surface, and we got to have an MRI or arthroscopic procedure to diagnose that. With that, the joint is stabilized and immobilized, and any kind of intra-articular fracture is probably going to lead to arthritis of that area. So you have these pictures in your textbook, but I wanted to provide it as a part of this. So you can see there the simple type or closed type of fracture is your first one there, where there's no skin integrity that's messed with there. And then of course the open where the bone comes through the skin. Comminuted is a mess there, you can see, where the bone is just splintered into several different fragments. The green stick is where the fracture is not all the way through. That's what we talked about as a hairline fracture there. It's not completely through the bone, but the bone is indeed broken. And then the oblique, you can see that type of fracture where it goes in an angle. A spiral fracture there, you can see what a mess that might be. The impacted fracture is where the bone fragments is driven into other bone fragments, where it's impact. And then the transverse is straight across the bone shaft. And then you have a depressed fracture, and you can see there this is like the skull area, or facial bones can also be a part of those types of fractures, like with a car accident or something like that. There's your avulsion fracture, which I talked about earlier. And the compression fracture you can see there with the vertebrae. Those types of fractures can happen especially with individuals who well, of course any kind of car accident or something can cause a compression fracture, but a lot of times you'll hear about the compression fractures with individuals who have osteoporosis, where they just sit down, where their bones are so weak they sit down the wrong way, or they cough, or anything can cause them to have a compression fracture. So our manifestations of a fracture, of course, is going to be pain, continuous, in fact, until it is immobilized, and also muscle spasms. A loss of function, so they're not going to be able to move that area wherever the fracture is involved. Deformity of the area and shortening of that extremity. Crepitus is that creaking sound. If you put your hand on my knee and I moved it for you, you would hear or feel, well, you can hear and feel the crepitus. Also localized swelling and discoloration, such as bruising, that kind of thing. And so it's most of these are diagnosed with an x-ray and by the symptoms, and then of course the patient is usually going to say it hurts to that area, but sometimes especially with those compression fractures and that kind of thing, they may be complaining of an area, but those are maybe not reporting pain in those areas, because they probably are having pain all over in their areas of their bones. So but usually the patient's going to report injury. So our emergency management is immobilization of the body part. That's going to be very important as far as helping with further damage to the area, and also helping with pain for the patient. So got to get that body part immobilized. Splinting, so we're going to see splints used to with the joints distal and proximal to the suspected fracture site, and so that helps again to immobilize the area and to support that area. We're definitely wanting to do those neurovascular assessments before and after the splinting, and then of course if it's an open fracture or a compound fracture, we want to cover that with a sterile dressing to prevent contamination of the area. And the emergency management is that you don't attempt to reduce that fracture at the site. You wait until the experts in that field take a look at it, get an x-ray, and see what kind of fracture we're dealing with here. Now the medical management is going to be the reduction, and you'll see and hear or read the word reduced. You'll see that a lot. So when we're saying that about a fracture, when a fracture is reduced, we're talking about reduction here. So a closed reduction is where an orthopedic surgeon will manipulate. Let's use an arm. Let's say that the wrist is fractured. So they'll manipulate, and they'll have an x-ray to begin with to see what type of fracture we're talking about. So let's say that it is a simple fracture. So they're going to manipulate the arm in a closed reduction and get that bone put back together, the two ends put back together, and then cast it, or probably splint it first, allowing edema to go down, and then putting a cast on. So there's no surgery involved. They've just manipulated that arm, putting the bones together using x-ray to assure that that's in fact has been done. An open reduction, or when open reducing happens, that means that they're going to surgery. So when we're talking about that, so let's think about one of those types of fractures that we saw. So let's say it's a comminuted fracture where all those little pieces are. They're going to go to surgery. They're going to have an open reduction, and when you have an open reduction type of surgery, and especially with that type of thing, what you're going to see in surgery is much like your daddy or your granddaddy's tool shed. There are plates and screws and nails and all kinds of hardware, hammers, all kinds of hardware with an orthopedic surgeon that they use to stabilize that fracture. So for a comminuted, they may use some plates to put those pieces of bone back together, plates and screws and that kind of thing. So we refer to that as internal fixation devices. So those are metallic pins, wires, screws, plates, nails, or even rods for that matter. And those things are used to hold the bone in place. So you'll hear that referred to as open reduction internal fixation. So the initials for that is ORIF. So when you hear or see ORIF, you know that means the patient has had surgery and they have nails, screws, plates, rods, whatever inside there to help the bone stabilize and keep it in place. Now after the surgery, there's definitely going to be immobilization for a little bit. And again, we're going to have that internal fixation devices that's going to, help stabilize that. But you also may see an external fixation device. And I have pictures of both internal fixation and external fixation throughout the slide. The external fixation is like, it's a crazy thing, and it looks um, quite the experience for clients that have to have that. But it's a temporary thing until the bone can be stabilized and healed, and then it's removed. The external fixation is. Um, Sometimes for internal fixation, those kinds of things are going to be permanent. Sometimes they, in fact, go in and remove those. So it just depends on the surgeon and where the fracture is. Definitely open fractures, which is also compound fracture. Got to have tetanus, antibiotics, and cleaning and debriding of the wound. Especially if it's a stage 3, but any stage, tetanus is going to be something that will need to be done as far as and also antibiotics and cleaning, and then closure of the primary wound may actually be delayed until edema is going down, and checking about the wound drainage and assessment of that wound to see about infection developing. Because what can happen if you get an infection of that wound, infection can then come of the bone. Not good. So there we're talking about osteomyelitis, and that's not good at all, and the bone will not heal. So very, very important to take care of those wounds with open fractures or compound fractures. Here are a couple of views of internal fixation. You can see those screws in A there. The screws going all the way through the bone, and they've used a plate there to stabilize that bone. You can see in B they've used screws there to hold that bone together. Most likely those will stay forever. There you can see it with D. They've got two types of fractures that's went on there, so, or two pieces, I guess, if you will. So they're going to put the top of D picture together with the bottom part of the bone, but they have the chip area there of that bone. They put it together with a screw. So, and then take a look at E. E has used a rod to go down and stabilize those fragments together. So it's pretty cool. Okay, so our nursing management for these, a closed fracture, we want to, definitely pay attention to the edema. And so elevation is going to be important, and pain management is going to be important. Exercising the unaffected part, because we want it to be strong. It's going to be, it's going to be overused because of the affected area won't be able to be used. So we got to exercise and keep that unaffected part strong enough to handle whatever the patient needs to do. Healing requires good blood supply, and depending on, where the fracture is, like for instance, flat bones heal quickly, comminuted bones take longer, long bones at the end are more vascular and heal quicker than those at the mid shaft. And weight-bearing exercises can help stimulate healing. So when we're talking about exercises, first we got to make sure we have an order to do weight-bearing with the affected area, but we for sure want to get that started as soon as possible. We've got to teach about the use of assisted devices. So again, if we got crutches, walker, canes, that kind of thing, we got to be sure that those are at the right height for the patient and that they know how to properly use this. And I know we think, well, we got physical therapy helping us with that, but not necessarily. I mean, if you're in the ER working, you may have to be the one doing that teaching, and it's very important because we know patients can have injuries with the use of those assistive devices. Fall risk assessments and interventions need to be done properly. CAS care, there's a whole section in your PEDS book about CAS care that you definitely need to be looking at, as well as in your Med-Surg book. The enhanced bone healing, take a look at that. Note what enhances and what inhibits bone healing. Enhancing bone healing is, for instance, immobilization. That, you know, when those that bone keeps moving, and there's fragments moving around there, that is not going to help the healing. So we got to immobilize that. Kind of like Humpty Dumpty. When they put Humpty Dumpty back together, he started healing a little bit better there. Maximum bone fragment contact also occurs with that immobilization, so that's why it's important there. Making sure we've got good blood supply. So managing edema is going to be important there, because when something's swollen, it's hard to get good blood supply to that area. Proper nutrition is also an important part of this. Exercise, weight bearing for long bones, and again, got to make sure we got an order for that, but that's important. Hormones also play a part into the bone healing, such as calcium D, calcitonin. So hopefully those things are okay with the patient. And the muscle contractions, the electric potential across the fracture. So certain exercises can help with that, and making sure that we're getting good, and that also, muscle contraction also helps with blood supply. So making sure that that is all going on is going to be important. Now with an open fracture, again, that whole wound issue is going to be extremely important. May have to irrigate and debride that wound, and it needs to be done as soon as possible so that infection is not taking place. May have to culture the wound, and there may need to be bone grafting going on with this type, depending on how serious the fracture is. So making sure that wound is good and clean, and getting those antibiotics and that kind of thing started on the patient is going to be really, really important. Once that wound is cleaned and taken care of, the fractures are reduced and stabilized, possibly with the external fixation. Internal fixator could be used as well, depending on what type of fracture it is. And again, with that, you may see that wound left open for 5 to 7 days to help with drainage and that kind of thing. So dressing that with sterile gauze to permit the edema and the drainage to occur, and just being meticulous about the care of that, so that we make sure infection doesn't get to that bone. Now, if we have external fixation going on with the patient, we'll have pin care to do, and that's specified in your book. about how to do that. So that is a nursing skill that's expected to do, and you may or may not have had opportunity to do this, but just be sure to look at that skill, because that's very important, again, if we've got an external fixator on the patient. And I'll show you a picture here in a little bit about that, but again, that helps us with not having, trying to prevent infection of this type of fracture. Now, complications of fractures or acute complications include shock, fat embolus, and compartment syndrome, DVT, and also pulmonary embolism. Delayed complications are our delayed union or malunion or non-union. Avascular necrosis is considered a delayed complication. Reactions to the internal fixator devices, that can occur because it's something foreign in the body, and so obviously if that occurs, we're going to have to get it out. Complex regional pain syndrome, CRPS, also known as reflex sympathetic dystrophy, is also a delayed complication, and heterotrophic ossification is a delayed complication. So let's talk first about our acute complications that can occur. You know about shock. Hypovolemic shock and septic shock are our most concerning. So our signs and symptoms of that, you know what to watch for there. A fat embolus is where, the long bones, remember that they've got that adipose there in the long bones, so in the bones. So long bones, pelvic, or any kind of crushing injuries, or multiple fractures are your most common types that can result in a fat emboli. Usually you see this in young adults, and the onset of this would happen around 12 to 48 hours after the injury. And so again, the fat is from the bone yellow marrow, and it effuses into the capillaries in the vascular area and travels, as you know, an emboli does. So you're going to see signs and symptoms here of hypoxia, tachypnea, tachycardia, and fever, pyrexia. Respiratory distress with shortness of breath and crackles. You might see thick white sputum that they're coughing up, and the x-rays of someone with a fat emboli shows a snowstorm infiltrate in the lungs, much like a pulmonary edema patient you would see. So without treatment, this can result in acute respiratory distress syndrome and heart failure. Also with the hypoxia, we're going to see, cerebral disturbances, so level of consciousness and confusion and that kind of thing. ABGs will show a low O2 with early respiratory alkalosis, and then a late sign is respiratory acidosis. You may also see petechiae, again a high fever. You may even see fat found in the urine if the emboli gets to the kidneys. And so renal failure can also occur with these patients. So the treatment is immobilization of that fracture, adequate support for airway ABCs there, for the fractured bones during turning and positioning, and we got to maintain support there, like log rolling or different types of pillows or things that we might use to support the fractured bones. We've got to maintain fluids and electrolyte on these patients, and of course the respirations. Again, we got to prevent that acute respiratory failure. You'll see high flow O2 used with these patients, possibly on a ventilator also, and corticosteroids will be used, IV, possibly vasopressors for the cardiac end of it to support that. So very serious type of complication that can happen and needs to be thought about for any kind of long bone, pelvic, or crush injury. Compartment syndrome is when an area that is encased by bone or fascia that has nerves, blood vessels, or muscles are being, compressed. And I've got some pictures, or I think I've shown you pictures of that already. And this is where, they're not going to get blood flow, and nerves are going to be compartmentalized, if you will, and muscles. And so, it's a very serious thing where it can potentially cause loss of limb. There's actually around 46 compartment areas in the body, and when a compartment syndrome occurs, it's sudden and severe, and there's a severe decrease in the blood flow to that tissue distal to an injured area, and it results in ischemia or ischemic necrosis. And so you'll see and hear from your patient throbbing and unrelenting pain, which continues even with pain medication. So the hallmark is pain that occurs or increases with any kind of passive range of motion. And it can result in permanent damage if it stays a compartment syndrome longer than 6 hours. So again, the 5 P's must be checked. We got to check that neurovascular assessment there for these patients, paresthesia, pallor, pain, paralysis, and pulselessness. We got to check the motion of the limb. Is there weakness? A late sign of nerve ischemia is weakness. No motion at all is nerve damage. So we want to prevent that for sure. Palpation, we want to palpate. That can, let us know about edema. And you can actually measure tissue pressure. There's a way to measure it. They call it a Wick catheter that can be used to measure tissue pressure, especially if there's an area that the physician or orthopedic is concerned about. So with our care, the nursing care, we want to elevate things at the heart level. And if it's a compartment syndrome, there may be, if a patient has a cast on, then they may actually make a little window in the cast. That helps, or bivalving the cast, they say. And then if that does not improve the situation in 1 hour, they have to go to surgery. And they do a fasciotomy, and the wound is left open. And again, going to elevate it at heart level or higher, and passive range of motion every 4 to 6 hours. DVT and PEs can also occur as acute injuries. Even DIC can occur with acute fractures or as acute complication. Now let's talk a minute about the delayed complications. So delayed union is where healing doesn't occur within an expected time, and that could be due to pulling apart of the bone fragments any kind of systemic or local infection or poor nutrition or other comorbidities of the patient. Um, it eventually heals, but it doesn't heal, in the expected amount of time. Now, a malunion, and anytime you hear the word mal, you need to think, okay, that's not normal. So malnutrition, you can use mal for many words, and we do in the healthcare field. So malunion is where the failure of the ends of the fractured bones, um, that they fail to unite in a normal alignment. And then non-union is a failure of the ends of the bones to unite at all. So non-union meaning they non-unite, non-union. The ends of the bones don't unite when they're put together. And we may see this with patients complaining of continued discomfort and abnormal movements of the fractured part. The causes of this can be infection, that tissue between the bone ends has interfered, inadequate immobilization or manipulation that's disrupt the bone formation, an excessive space between the bone fragments, limited bone contact, or a poor blood supply. So treatment of the malunion and non-union it could potentially be bone grafting, allografts or autografts, and then after grafting they must immobilize and have no weight-bearing exercises until that graft actually takes place, or the graft actually starts healing. And of course they can have complications from that, such as wound infection, fractures of the autograft, and just may take a while to heal. Also, you can see the electrical bone stimulator used on this. It's a non-invasive type of procedure that the patient puts on the fractured area, and you can, I've seen this a couple of times, and one case it was seemed to have helped. Another case it seemed not to help, or didn't do any, was not beneficial. But the thing is, they have to keep that on for about 12 hours every day. Now, nursing care, of course, with this is that we're going to manage the patient's pain, wound care, and of course provide passive range of motion exercises and exercises of that unaffected part. Avascular necrosis is where the blood supply is gone from the area, and you can see this not only with fractures but also dislocations, bone transplants, prolonged high doses of corticosteroids, chronic renal disease, and sickle cell anemia patients can have this. So basically what's happening here is the bone collapses or resorbs, and the pain that the patients are going to experience is pretty bad and severe, and they're going to have limited movement. So the treatment is going to be with bone graft or a prosthesis replacement, or a joint fusion may have to take place there. Complex regional pain syndrome. The patients here are going to be complaining of severe burning pain, so we know that nerves are involved when we hear that. Also local edema, and hyperesthesia, stiffness, discoloration, and vasomotor changes can occur. Fluctuating warm, red, dry, and cold, sweaty, cyanotic. So our nursing management with this is elevation and immobilization that allows for you know, range of motion that can be done and functional use uh, of that extremity. We want to use rest for the affected extremity and provide early pain relief. Um, and avoid using the affected extremity for blood pressures or any kind of venipunctures, because that can stir up their RSD on that, or your complex regional pain syndrome. Heterotrophic ossification is a weird type of thing that can happen. It is abnormal formation of bone near bones or in muscles in response to soft tissue trauma or treatment after blunt trauma or after a total joint replacement. And I have a good friend that actually has this going on. He had to have a hip replacement done, and he had bone forming over that hip replacement. And so they literally had to go in and chisel out bone growth that occurred. And that helped for a little while, but unfortunately he is having new bone growth over that prosthesis again. So it's kind of a weird type of thing that you'll see from time to time with different patients. Okay, you can see in this picture a compartment syndrome that is occurring, and your A picture is a normal, what it should look like, but then you start seeing on the B side some things of where the swelling might be taking place, and that the compartment is, the nerves and the muscles are getting compressed, I guess is the best word to use, and where that might be problematic and eventually lead to loss of that limb. So very, very important to get that taken care of. And there's a picture of that WIC catheter used to monitor compartment pressure. Okay, let's talk specifically about some different types of fractures that occur. So our clavicle is an area there where if we have a fracture in that, we have to monitor the circulation and nerve function of the affected arm, and that's, we're talking about our collarbone here, our clavicle area. So we want to compare one arm with the other arm when we're doing that neurovascular status. Some breaks are with the dislocation will require an open reduction with internal fixator, so an ORIF. If it's a simple fracture or dislocation, you're going to see the figure 8 or figure 8 sling placed on the patient. I've got a picture of that here in a minute. With this type of injury, we don't want to raise the arm above the shoulder, but exercise the elbow, the wrist, and the fingers. And eventually the shoulder exercises will be done once they're ready. Then we're talking about the humeral neck and shaft fractures. Of course, slings and braces are going to take place there. So we can see the humeral can have like a neck, the humeral neck fracture, which can also involve the rotor cuff damage. That and I showed you a picture of that earlier. Again, we got to assess neurovascular in the arms, and the got to make sure that immobilization is done. That's going to be very important with slings, and we want to support the extremity close to the trunk. And then, of course, they're going to exercise that to keep that shoulder moving. Um, and you'll see the exercises are like a pendulum exercise. And so you can see here where the collarbone is fractured in that picture of the A, and then the figure 8 sling is used to put it back in place and to help with the immobilization. This is shoulder exercises that you can see. That first one there is like your pendulum swinging, and then the climbing of the wall. So these are different exercises that you'll see of those shoulder exercises once they're ready. And this one is, you can see the type of sling that's where it holds it close to the trunk. And of course, again, we got to do those assessments before and after those slings and splints and braces are used to put on the patient. And then here's another type of brace that's placed on there for the humeral brace. That's where the humeral shaft is broken. And then the patient also has that sling on to keep that area. So, definitely it's going to be important there to exercise those fingers, wrists, all of that area of the affected arm. Okay, the elbow fracture, we'll talk a minute about that. That definitely can happen, and we want to again assess that neurovascular part and for signs of compartment syndrome. The area here is called Volkmann's contracture, and that is a compartment syndrome that is where the antecubital area has swelling, and it can compromise the that area and damage to the brachial artery. They can also have damage to the joint articular surface and hemarthrosis, which is blood in the joint. So with that, we're going to, see the patient's fracture reduced and stabilized, and a splint may be used. They may also have the open reduction internal fixator for that. So again, any kind of fracture like this, it's going to take a little while to heal, and we want to do those exercises with the patient, especially gentle range of motion 1 week after the injury. Active finger exercises are going to be needed too. Now, the Colles fracture is a wrist fracture, and that's the radial head. And again, we got the immobilization that's going to take place with a splint, and they can't lift anything for 4 weeks. If it's displaced, then surgery is going to be needed. And these are common in children, the radial and ulnar shafts, common fractures with children. And many times these can be handled with closed reduction. So we know we're going to do our circulation motion sensation check, neurovascular check on these patients. We want to elevate the arm. We want finger flexion and extension exercises and range of motion of shoulders to take place with this as well. And of course, we're going to have to do cast care and teaching for the patients and or family members. Our pelvic fracture is where there is a high mortality rate, and it's due to hemorrhage and pulmonary complications, fat emboli, thromboembolic, and infections. So the signs of a pelvic fracture are going to be bruising, tenderness over the symphysis pubis area, the anterior iliac crest or sacrum or coccyx area. And so we may see local edema, numbness and tingling, and unable to walk. So we want to do neurovascular checks of the lower extremities when this occurs. Also, we need to assess for urine, the urine for blood, because fractures can lacerate the bladder, or other other areas that are there. So we don't want to do a Foley catheter on a client with a suspected pelvic fracture until that is ruled out. Unstable hip fractures usually bleed a lot, so these patients may indeed need blood transfusions. Now, so again, the pelvic area, we're talking about the pelvis. With the hip, when you hear hip fracture, we're talking about the top of the femur. So there's two types. The intracapsular hip fracture is the neck of the femur. Extracapsular is between the base of neck and lesser trochanter of the femur. With that one, you'll see a leg shortened. The leg is adducted and rotated. They're going to complain of pain in the hip and the groin area and pain with movement. Watch out for your elderly here because they can have major complications. Edema, respiratory problems, atelectasis, pneumonia, dehydration, delirium, infection, blood loss, immobilization, that kind of thing. So we got to watch about that. Now, our treatment possibly for your hip fractures can be buccal traction, and we'll see a picture of that in a minute, and that will help with pain relief and stabilization. So let's take a look at some pictures here. So this is your pelvic bone, a normal pelvic bone, no fractures or anything, so just kind of see that and the different areas there. And then we're seeing some stable pelvic fractures. You see there one of the pelvic wing, the sacral area, the pubic bone area also, and those again are stable, considered stable fractures. And then you see a picture of the unstable area. So like in your A picture there, that is the symphysis pubis area is fractured basically, and ligaments are pulled apart. And then you can see the fracture up at the top there as well. Then in the B area you can see the fracture at the top there and ligament down below that, and then again the symphysis pubis area. And then in the C part you can see there is the acetabulum part of the fracture is fractured there where the femur comes into the joint. So these are going to have to go to surgery, and most of the time, and they're going to have to have some kind of internal fixator or even possibly a total hip replacement done. Then here is a picture of the femur where you can see the neck of the femur being broken, or as the intracapsular area, and then the extracapsular area is the rest of the femur being affected. So here's some examples of our internal fixation of the hip, where screws and plates are used to help stabilize that, and those will stay in forever. Okay, so our nursing process, we're going to look at pain management here being their, important thing, and to prevent complications. So, we want to do a good health history and what's the presence of concomitant problems or comorbidities or other health problems that's going to be giving us a little headache here, such as, if the patient's a diabetic, is their healing going to be as good as someone that's not a diabetic? Does the person have heart failure or any kind of heart problems? Is the person on corticosteroids? Is the person, a COPD patient? So, other problems, concomitant problems, we have to definitely consider when we're talking about these patients. Pain management, again, is going to be an issue that we want to work with the patient on. We want to assess those vital signs, respiratory status, level of consciousness, and signs and symptoms of shock, because remember, these areas can have a lot of blood loss, so we want to look for that, and that we can also have infection. So want to both monitor for hypovolemic and septic shock. We got to assess those affected extremities frequently with neurovascular checks, and of course our bowel and bladder elimination is going to be impacted here because we're going to be on bed rest temporarily. So that's going to be impacted, and mobility is going to be impacted, so we want to pay attention to that. Also, we got a patient that's going to surgery, so we got to listen to those bowel sounds, make sure there's not any kind of signs of paralytic ileus. The other thing with these patients, we're talking about, with the respiratory end, we want to do the deep breathing, incentive spirometer, good post-op care there, because the patient's going to be having surgery, most likely. We want to do prevention of DVT, so we got to do those foot exercises, the dorsiflexion and plantar flexion exercises. We want to keep the patient hydrated, and nutrition, being optimal, and of course monitoring that urine output. On these clients, we're going to use an abduction pillow that's placed in between the lower extremities to help with alignment, that keeps alignment, because we don't want the patients to ever cross their legs. We're going to log roll for turning, and we'll turn to the uninjured side with pillows between the legs. So you may also see a trochanter roll used with this as well. So we got to watch about the skin condition too, as far as their wound, watching for signs and symptoms of that, but also watching for pressure ulcer development also. Okay, here are some of our nursing diagnoses that's going to be involved in caring with patients with hip surgery. The part about ineffective coping, I mean, we got to think about these patients, guys, as far as, what's going to happen with them when they go home, or what's the plan for them. So getting case management involved with these clients is going to be real important, because, they can go to a skilled unit where there's physical therapy that's being done, and those are offered in our nursing homes, or there's rehab hospitals out there as well that the patient can go to. So working with them on coping and getting the disciplines involved to help with that. Of course, physical therapy and occupational therapy is also going to be a part of the team that helps work with them, and this will help with the coping. Disturbed thought process, when patients are bedridden temporarily, or medications that we're giving them for pain can cause some disturbed thought processes. So we want to keep a check on their orientation status and make sure that's not going on. Also, they're at risk for infection as far as UTIs, and constipation, and those can cause confusion as well. So we want to keep all of that, in check. Of course, we want to definitely watch for those complications that can happen with these, such as hemorrhage, peripheral neurovascular dysfunction, DVTs, pulmonary complications, and pressure ulcers. With our pulmonary, we're talking about atelectasis or pneumonia. A loss of bladder control may occur. So we got issues that can happen there. We can have delayed complications such as non-union. We can have avascular necrosis that can occur. Um, we can have issues with the the internal fixator devices. Problems with that can occur. Where the patient's starting to react to that. Um, so, and certainly infections can occur. So we got to watch for all of that kind of thing, monitor the vital signs. Be sure to look at your care plan that's in your book. I'm not sure what the page number is, but it's chart 43-5. So be sure to look at that. These just list what our goals are, or planning for the patient. We want them to be relieved of pain, and we want them as functional as they can be, and stable as they can be. We want to stabilize that hip and make sure that the bones are healing and the wound is healing, and that they have a normal urinary pattern and bowel pattern too, and that they are oriented and they participate in that decision making, and they do not have any complications. So relief of pain, again, we're going to give meds as prescribed, but Buck's traction is another thing that can be used for muscle spasms and for pain relief. And so the whole caring for anybody in traction needs to be looked at with this. We got to watch our ropes and our the pulleys and things like that. Make sure that the weights are freely hanging and not on the bed or not on the floor. It's not doing any good there. Also, we want to support extremities with pillows and when we're moving the client, and we want to position that client for comfort, and turn every 2 hours, that kind of thing, and alternate the pain relief methods. We also want to promote that physical mobility. Overhead trapeze bars are excellent, and they can also help with arm strengthening for the patient. So that's going to be real important to get that patient a trapeze bar. We want to maintain that neutral position of a hip. Extremely important. So there's going to be specific rules that the patient's going to be instructed about. For instance, not crossing the legs at all. They cannot do that. So we may need, again, to use those abduction pillows, a pillow in between the two legs, and also the trochanter rolls on the outside of the thighs, and also teaching them about isometric, quad sitting, gluteal setting exercises, the assistive devices such as hip walkers and crutches. Walkers is what you usually see, and then they graduate to a cane. And again, we're going to have physical therapy and occupational therapy, involved in the care there. And usually after the hip surgery, now they're getting them up. Sometimes the day of surgery, physical therapy will be in there, at least getting them up to the side of the bed or in a chair. They want to start that as soon as possible. So when we're caring for patients, we got to get in there and make sure they get pain management, pain relief, so they can get that physical therapy done. Because the more they move, the better it's going to be. So we're going to be their coach and helping with that kind of thing. Obviously, other nursing interventions, we're going to use aseptic technique when we're doing dressing changes. Um, we want to avoid using a catheter if at all possible because we don't want any risk of infection for these patients. We're going to be our support in coping with the patient and get all the things that they need. We want that social worker or case manager involved, and the family involved, so that we can get the patient's care planned, for once they're discharged, and that they're covered while they're in the hospital under our care. Orienting patients to and stabilizing the environment, making sure that we don't have anything that's going to cause them to fall. All of that's going to be important, and we want safety. Patient safety's got to always be our concern. Patients got to participate in their self-care here, so we want to encourage that. We're going to do those coughing, deep breathing, incentive spirometer. We're going to make sure they're getting adequate hydration and DVT prevention with the TED hose or the SCDs, doing their leg exercises, ankle exercises, and of course teaching and providing care, and teaching for the family to make sure everybody is on the same page. Okay, enough with the hip and the pelvic fractures. Let's talk a minute about femoral shafts. This, obviously is going to be your long bone of your femur. Those are pretty serious fractures because we can lose a lot of blood here. So you'll probably need to measure the thigh, and keep a measure of that, the diameter of it, to make sure about compartment syndrome. With this type of fracture, and any fracture, we're going to do our neurovascular checks. Now, with this type of fracture, they may have to have skeletal traction, where the traction is connected to the bone. And I've got a picture of that here in a second to show you. Certainly splinting for immobilization is going to take place, and could also be an open reduction with internal fixation. So you can see this different fracture areas of the femur that can take place, and you can see in the C picture where you've got skeletal traction. That's going to the arrows are going to show you where how that traction is going to be applied to that particular thing. But you can see the traction literally goes in through the skin to the bone. Now this is a picture that I've been promising. It shows you an external fixator, and so you can see how it's connected directly to the bone there, where screws are placed in, and the apparatus outside of the skin can take place that's what happens with an external fixator. So you can see that whole gizmo there outside of the thing, and of course that's temporary. It's eventually going to go away, but anyway, it's certainly hard for the patient to initially work with that. Now you can see where the pins are coming out. They're connected. They're going all the way through the bone, and then out through the skin, and then to the external fixator. So this is where pin care will be done. And think about how important that pin care is going to be, because the pathway of that pin goes straight to the bone. And again, osteomyelitis, not a good thing. Not a good thing at all. And bone won't heal, and potentially they can lose a limb because of that. So this particular fracture is a tibia fibula fracture, or tib fib fracture. And again, we're going to have to watch for that compartment syndrome there. And you can see how complicated that's going to be for sure. Okay, ribs and spines. Ribs, of course, we're at risk for any pulmonary problems there. We got to make sure, checking good breath sounds on the patient, watching for symmetry of their breathing, because they can actually get pneumothorax, hemothorax, or flail chest with rib fractures. Also, we're at risk for atelectasis and pneumonia. So that can be a problem. So we want to support the patient with our hands to assist with deep breathing and coughing. That's going to definitely need to be done for these patients to prevent any kind of complications. With our spine, we got to make sure the spinal cord is not affected, but it's going to be important that we keep alignment, with any kind of spine fracture. Stable fractures of the spine are treated with bed rest, and head of bed elevation is less than 30 degrees. We want to manage the pain, and we got to assess for paralytic ileus, and these patients may end up with a spinal brace. Unstable fractures of the spine will need surgery. So we're going to do neuro exams to check for any kind of damage. We're going to do neurovascular checks as well, and immobilization is going to be essential for that. Now this is a picture of a halo, what they use, which is an external fixator, and you can see it goes around the patient's head. And then it goes over their shoulders there, and that's how it's kept in place. So that will have to stay in place, until there's healing that goes on, and this is used for cervical spine fractures with that. So I just wanted to show you a picture of that. All right, that concludes your podcast.